Hello everyone, welcome to the second ECMM webinar together with Healthbook. The topic today is mucormycosis and other rare fungal infections. So we had a very successful webinar a few weeks ago on resistance in mold infections and resistance in Aspergillus specifically, which is for everyone who could not join at that time now available on demand. So everybody who missed that first webinar is still invited to look on the on-demand version. But I think with that, let's now fully focus on mucormycosis and other rare fungal infections. So it's my pleasure to have this webinar virtually hosted by Israel, where my co-chair, Professor Esther Segal, is from. And Esther is here with me, and I will hand over to her in a few seconds after a few welcoming slides. In terms of speakers, we have Professor Dr. Ronen from the Tel Aviv Sourasky Medical Center in Israel. And then we have Professor Dr. Jean-Pierre Gangneux from the Centre Hospitalier Universitaire de Rennes in France. And finishing up, Professor Frédéric Lamoth from the Centre Hospitalier Universitaire Vaudois in Switzerland. So in terms of topics, after this quick introduction, Esther will introduce the first speaker, Ronen, who will present a clinical case on rare mold infection and outline the clinical challenges. This will be followed by a translational session presented by Professor Gangneux on the specific diagnostic challenges in mucormycosis and rare mold infections, followed by a clinical session by Frédéric Lamoth on invasive rare mold infections, focusing on the epidemiology, therapeutic challenges, and novel therapies on the horizon. After that, there will be a conclusion. As a short housemarking remark, you're of course welcome to ask your questions anytime via the online tool, via the chat function, and we will try to answer as many questions as possible after each of the talks immediately, with some other questions that may have been left over because we don't have enough time. We try to answer during the rest of the webinar or later on via email. And with that, of course, it's my pleasure and of course also my duty to thank not only the ECMM but also Healthbook, who really provided this webinar and organized this webinar in a, I think, great working partnership. And not last but not least, definitely our sponsor, Gilead Sciences, and further co-sponsors, but definitely want to name out here Gilead for making this webinar series possible. Just showing the disclaimer, and while showing the disclaimer, I can already hand over to my co-chair today, Esther Segal from Tel Aviv in Israel.
Good afternoon or good evening, wherever you are. My name is Esther Segal, and I have the honor to participate in this webinar as a co-chair. I am from Israel, from Tel Aviv University, the medical school. And it is my pleasure and honor to introduce to you the first speaker, Professor Dr. Ronen Ben-Ami. I have not prepared any CV, but I can say a few sentences which would describe Ronen and his work. Ronen is a graduate of the Tel Aviv University Medical School, and he is a specialist in infectious diseases with specific interest in fungal infections. Ronen, I remember from years back when he was one of the students in a special course we had in medical mycology. From there, he continued to other places, and particularly to MD Anderson in the US, working with various people and having seen from first hand what fungi can do. And now he is very knowledgeable on fungi, and he will describe to you a very interesting case. I saw the slides, so I am basically giving the podium to Ronen. Please, Ronen.
Okay, thank you, Esther and Martin, for the opportunity to present today. I will just share my screen. Okay, so these are my disclosures. I would like to open just by saying that I was consulted about this case, but in fact, this patient was managed by my pediatric colleagues, and specifically Professor Galia Grisaro from the Dana Children's Hospital, who was very kind and allowed me to present this case today. So the patient was a 4-month-old female who became ill at the age of just 3 months when she was being treated for RSV bronchiolitis, and then she was diagnosed with acute myelocytic leukemia in the same hospitalization. And at the age of 4 months, she was started on treatment with mitoxantrone, etoposide, cytarabine, and very rapidly developed neutropenia and then febrile neutropenia. She had an episode of neutropenic enterocolitis, but that resolved, and actually the clinical picture was dominated by persistent fever and cough. On day 10 of her neutropenia, she had a positive PCR test from a nasopharyngeal swab for parainfluenza virus. After that, a chest CT was done, which you can see here showed airspace densities in the lower lobes. And with this finding, voriconazole was started empirically. Soon after that, this patient develops skin lesions, which are subcutaneous erythematous nodules on her upper and lower limbs. Voriconazole serum level was measured very close to the time that these pictures were taken. It was 1.4 micrograms per ml, so within what we would consider a therapeutic range. And soon after that, her blood cultures become positive. I would just like to point out, when you look at these blood culture smear results, if you just look at the left side panel, you would very easily be led to think that this patient has yeast growing in her blood culture, but in fact that would be a mistake. As you can see, 2 types of fungal elements here, both yeast cells or yeast-like cells and septate hyphae. And this is something that can certainly lead to erroneous treatment. This is what grew on the culture plates on the Saburo agar. You can see here on the front of the plate, these are white, brownish colonies. On the reverse side, we have this brown color. And in the slide with lactophenol blue, these microconidia. The rightmost panel is actually not from this patient, but is given here just to illustrate what the macroconidia would look like. And this is, of course, a giveaway. Once you have this morphology, you should know that you're dealing with Fusarium species. So this isolate was identified using Malditov as a Fusarium solani species complex with a high degree of confidence. And then with ITS sequencing as Fusarium petroliphyllum, a species within the Solani species complex. And the patient was then assumed to have disseminated fusariosis. Her treatment was switched from voriconazole to liposomal amphotericin B at 5 milligrams per kilogram, and GCSF treatment was also started as she was still profoundly neutropenic. This is the antifungal susceptibility testing that was obtained using broth microdilution. This isolate was completely resistant in vitro to azoles, voriconazole, posaconazole, and itraconazole, as we often see with Solani complex. And the MIC for amphotericin B was 2 milligrams per liter. So from here on, the patient seemed to be improving, fever gradually resolved, there were no new skin lesions, and her neutropenia resolved after 33 days. However, very soon after she emerged from neutropenia, her respiratory status worsened acutely with worsening dyspnea, tachypnea, and diffuse lung crackles. Her O2 saturation was 90% using a nasal cannula and 3 liters per minute of oxygen. And her chest CT showed new findings. You can see here, when we compare it to the previous CT that you just saw, these new nodular lesions, which are shown on both lungs. So when we have this type of clinical worsening very soon after a patient recovers from neutropenia, we think about 2 possibilities. One is that this might be an immune reconstitution inflammatory syndrome, and the other that this might be progression of the fungal infection. And so to resolve this question, the patient underwent bronchoscopy with BAL, and from the lavage, PCR was positive for parainfluenza virus, calcofluor stain was negative for fungi, but culture grew Fusarium solani species complex. So at this point, the patient also has new skin lesions that appeared on her limbs, trunk, and face. A punch biopsy was done from one of these lesions, and calcofluor stain showed septate hyphae. She also had multiple swelling in her joints, specifically left knee, right wrist, and elbow. And you can see here the CT scan from the right wrist, and we see here this destruction of the right distal radius consistent with osteomyelitis. At this point, liposomal amphotericin B was increased in dose to 7.5 milligrams per kilogram per day, and IV posaconazole was added. And the patient underwent drainage and irrigation of the left knee joint. The intraoperative findings were of cloudy synovial fluid with white membranous material. Cultures from that were negative. However, the specimen was also sent for pan-fungal PCR, and that was positive for Fusarium species. So 2 weeks after this surgery, when the patient appeared to be stable, the hematology team decided that she needed to continue chemotherapy, and without that, her prognosis would be quite poor. And so she was started on cytarabine, daunorubicin, and etoposide, again became neutropenic. We're now up to January 18th, 2020, and was given granulocyte transfusions and GCSF. You can see here what happens in February, soon after this neutropenia. We have the same skin lesions that appear to be more red and fleshy, and this new swelling and erythema over the left ankle. And a CT scan of the ankle shows destruction of the left talus and soft tissue swelling with hypodense fluid collection around the joint with some peripheral enhancement. Okay. Again, a punch biopsy was done from one of the skin lesions. Calcofluor stain was positive for septate hyphae, and the posaconazole dose was increased to 7.5 milligrams per kilogram per day, and was monitored to ensure therapeutic levels. The decision now was to avoid any further surgical intervention. So the understanding at this point was that further neutropenia could be very harmful for this patient, and her chemotherapeutic regimen was switched to monthly azacitidine. She remained in complete remission, and most of the lesions on her face, limbs became flattened scars. The swelling in her left ankle resolved, and a CT of the chest, abdomen, head, and limbs showed partial resolution of her pulmonary nodules, but still multifocal osteomyelitis involving the left talus, calcaneus, left fibula, left and right radius bones. So this is what things looked like by May of 2020. You can see that these lesions are still there, but they seem to be flat and not active, and no new lesions. And things are going quite well. However, in May 2020, her leukemia relapsed. And so she underwent 2 reinduction courses. After each of those, she became neutropenic for 4 to 5 weeks. And she was treated with G-CSF and granulocyte transfusions during those periods. And she continued to receive combination therapy with liposomal ampho-B and posaconazole throughout this period. In October of 2020, when she was now aged 15 months, she underwent allogeneic stem cell transplantation from her mother. This was a haploidentical transplant. She engrafted on November of 2020, and she had a severe complication of alveolar hemorrhage. BAL that was done at this point was negative for bacteria, fungi by culture and PCR, and she improved with supportive treatment and corticosteroids. Overall, liposomal amphotericin B was continued until January of 2021. So this is a total of 14 months. At that point, her renal function started to deteriorate and treatment was stopped. Posaconazole was continued up until March of 21, a total of 153 days from her transplant. And on follow-up, she had no recurrence of her skin lesion, no new bone or lung lesions, and she was ambulating by herself and doing quite well. So a little bit about Fusarium species. These are pathogens of plants and animals. They are very widely distributed in nature, in soil, in plant parts, and in water systems. And infection usually occurs either by inhalation of airborne spores or through traumatic injury to soft tissue because of trauma, because of burns. And these can really give rise to a range of clinical syndromes that depend to a large degree on the immunological state of the host. In immune competent persons, we find superficial or locally invasive infections. These can be soft tissue or bone infections, keratitis, often associated with contact lens use, onychomycosis, and allergic fungal sinusitis, as well as foodborne mycotoxicosis. In patients who are neutropenic or have severe T-cell deficiencies, we tend to see either disseminated infection, as in this patient, or invasive pulmonary disease and invasive sinusitis. The taxonomy of these organisms is complicated and also controversial. There are around 200 species that are arranged in 10 species complexes, but very few of those species actually cause human disease. So if you look at clinical disease, around 60% of that is caused by the Solani complex, 20% by the Oxysporum complex, and there are only about 4 actual species that we find in most of these infections. These are Fusarium keratoplasticum, Fusarium petroliphyllum, and then 2 species in the Oxysporum and Dimerum complexes that are only identified by their sequence types. So disseminated fusariosis has this very typical triad of components, all of which were present in this patient. We have a site of inoculation, which is most often the respiratory tract, but can also be the skin around nails or the legs. Then we have dissemination through the bloodstream and seeding most often of the skin with these very typical skin lesions, subcutaneous nodules that might ulcerate, and then other organs such as bone and liver, spleen, and other viscera. This is typically associated with very poor prognosis. When Marcio Nucci summarized the experience with stem cell transplant recipients in 2004, he found only 13% survival at 90 days, with persistent neutropenia being the main risk factor for death. However, this figure has improved somewhat, and that's associated with better treatment options than amphotericin B deoxycholate, with the availability of voriconazole and liposomal amphotericin B alone or in combination. The diagnosis can be made in several ways. This is one of the very few mold infections that can be diagnosed by blood culture, which is positive in around 40%. And actually, patients who have a positive blood culture tend to do worse. The fact that blood cultures can be positive is attributed to the adventitious conidation that this species is able to produce. We can also make a diagnosis using a biopsy of skin lesions. Calcofluor white staining, as in this case, is a very simple test. It can give us some quick information, and then of course culture. Galactomannan can be positive with a sensitivity of greater than 80% and 67% specificity, and can precede the clinical manifestations. This has been shown and published. I admit that my own experience with galactomannan in fusarium hasn't been actually so good as those papers. And then a broad range fungal PCR, which was done here. This was done in the Rambam microbiology lab in Haifa. This is not routinely available, but can be useful if you can get access of this test. To identify fusarium, you can use more classic morphological methods, but that will usually get you the genus and species complex. To actually get the species, you need to use molecular methods, either sequencing or Malditov, which is actually quite good for identification of fusarium species. If you are doing sequencing, ITS was useful in this case, but is not the recommended sequencing target. Elongation factor and RNA polymerases are better at differentiating the various species. There are no randomized controlled trials on the treatment of fusarium, so what we have is just observational data. And this is probably the largest case series showing that patients treated with voriconazole or liposomal ampho-B did better than those treated with ampho-B deoxycholate, and neutropenia as well as treatment with corticosteroids were predictive of poor outcome. Combination therapy is used in many centers, including in our center. It's not really very well supported by the data. As you can see here, there's one multinational cohort that showed a lower mortality using a combination of liposomal ampho versus monotherapy with either of those drugs. However, a multi-center French cohort did not show any difference between those treatments. Of course, there are many biases when you examine data like this, and we would assume that patients that received combination therapy were the sickest patients and those at greater risk of death. And these are things that we need to consider. What about the MIC? Is it useful to guide therapy? This is more data from Marcio Nucci showing the MIC distribution for patients who survived or died on treatment with voriconazole, liposomal ampho-B, or combination of those drugs, showing really that there is no difference in the distribution of MICs. So clearly, looking at this data, we cannot form a clinical breakpoint for any of those drugs. However, if the question, I think, is a little different when you look at in vitro susceptibility and see absolutely no inhibition by a drug, as was in this case. If we look at this specific data set, 21% of survivors had MIC of voriconazole around 16, and that was true for 37% of patients who died. So I think the verdict is, the jury is out on this topic. Manogepics, a new drug which is currently in clinical trials, seems to be promising for the treatment of fusariosis, consistently shows good in vitro activity against Solani and Oxysporum species complexes. And we have promising data from a small case series presented at ECMID 2021. 83% of these 12 patients had a favorable response, including those with CNS and eye infections, and patients who had ampho-B-related nephrotoxicity recovered renal function on phosphamatogepics. So there are many areas of uncertainty with fusariosis. What is the role of surgical treatment? You saw that we used it to some effect in this patient, but not on all of the lesions. What is the role of combination therapy? How do we use in vitro testing to guide treatment choice? And do we need new modalities of in vitro susceptibility testing? And I think there's still much to do and much to learn about fusarium. So with this, I will conclude this presentation. And again, I'd like to thank Professor Gallo Grisaro and also Professors Marcio Nucci and Andreas Grohl, who provided very valuable consultation in real time about this case. And my friends at the microbiology lab, Ella Burdolova and Anna Novikov, and of course the doctors and nurses at the Dana Children's Hospital who treated this patient. Thank you very much.
Thank you so much, Ronen, for a fantastic
I would
talk.
like to add. I would like to add something. Ronen, first of all, thank you very much for the very knowledgeable and very detailed case presentation. It is really very impressive. And there were several questions in the audience or in the listeners that maybe you have seen already, which I referred to you.
Yeah, so I will just highlight some few because we have 2 minutes now for discussion, but we can still answer the rest of the question while the seminar is ongoing. I think one important question was basically about dosing of antifungals in infants and children's. What do you recommend as guidance for finding, dosages in these, in our small patients, basically, in the absence of, broadly accepted guidance documents? And do you have like any reference you would particularly recommend here?
Yeah, so my reference is the very extensive guidance that was published by Grohl and colleagues in, I believe it was Lancet Oncology, where all of these doses are very methodically summarized. It's true that we do have limited information for the pediatric population, but we do actually have pharmacokinetic data for these drugs. And so the dosages were the doses that were recommended in that document. And I think that really TDM is something that we need to use in those pediatric patients, certainly when we are dealing with a pathogen that is multi-drug resistant, as in this case, and we want to try to aim maybe for the higher margin of dose range or concentration range that's possible for each of those drugs.
Thanks so much. And just to add, I mean, there's also a recent guideline kind of like specifically for Fusarium. So I think, I think Ronen's reference is perfect for antifungals in general, but specifically if you're dealing with Fusarium in children, you can also use the ECMM, ISHAM, ASM guideline, and not the main document, but the supplement. We basically find, a detailed table of all pediatric cases treated to date and see, which doses work. But it's, I think it's often single cases or small case series, so we don't have a lot of evidence beyond that. So we mostly go with evidence that we have from adult patients. But nevertheless, if you want to go into more detail specific for the pediatric population, I recommend to go into the supplement of this guideline.
I would like also to add that some of the participants asked what was the basis of choosing this specific drugs. So maybe you should say a few words on that. It would be very, very good for the audience.
Yeah, so as I mentioned, we did consult with Professor Nucci when we treated this patient. I think one question that we had in mind was whether we should think about this case as a breakthrough infection. The first clinical manifestations appeared just 4 days after the patient was started on voriconazole, which might be a bit early to actually consider this a breakthrough infection. However, at that time, the patient did have a therapeutic drug level. So it was kind of difficult to continue using voriconazole under that situation, which was the main reason for us to switch to liposomal amphotericin B. However, there is a good experience with both voriconazole and posaconazole in the treatment of fusariosis, and those drugs do have better penetration into various tissues, including the CNS and the eye, as compared to liposomal amphotericin B. Given the complexity of this case and the fact that this did behave like a breakthrough infection, we decided to use combination therapy. I see here a question about how well that drug combination is tolerated. In this case, it was tolerated quite well. I think the main limitation here is usually the amphotericin B, not so much the azoles, which tend to be better tolerated. We were able to actually continue both of those drugs for a very extended period of time, as you saw.
Thank you so much. I think with this, we want to thank you, Ronen, so much for your talk. So there's also the options for you to answer directly to some of the other comments, and I will do the same basically via the small reply button on the chat while the seminar is ongoing. But now it's my pleasure basically for us to stay in time to introduce Professor Jean-Pierre Gangneux, who all of you probably know. He's serving as the General Secretary of the ECMM. He's truly one of the leaders in the field. His affiliation is the Rennes Teaching Hospital at the Rennes University, where he's heading the mycology and parasitology unit there. And he's very active as a national leader in France, head of multiple multi-center studies throughout France, but really not only France, but Europe and the mycology world. And it's my special pleasure here to welcome him to talk about specific diagnostic challenges for mucormycosis and rare mold infections.
Thank you very much, Martin, for your kind introduction. So indeed, I'm going to talk on diagnostics. If you want to have many details on mucormycosis and rare mold infection, of course, you can go to the publication of the ECMM and ISHAM guidelines that were coordinated by Oliver Corneli and Martin Hoenigl. And in these papers, you will find many references and many information regarding this disease. But regarding mucorales, Fusarium, Glomontospora, and Scedosporium, you will find all the process from epidemiology to treatment. What I want to discuss with you today is a more practical approach and to see what happens in the real life. What happens in the lab is that we receive some samples, and we can receive blood, such as blood bottles, serum, plasma, but also respiratory samples, BAL fluid, tracheal aspiration, sputum, biopsies, and sometimes cutaneous samples. And with all these samples, the aim is to perform the diagnosis, and we want to detect not only rare molds and mucorales, but we want also to detect pneumocystis, aspergillus, and yeast. So how can we go further? One first step is to know the background of the patient. And if we are in front of a patient that is immunosuppressed, then it will be really important to implement some analysis regarding blood with blood culture, antigenemia, PCR. Regarding respiratory samples, mainly BAL, that will be the more informative samples in immunosuppressed patients. And then we will want to go to the final diagnosis after direct examination, culture, PCR, antigenemia. And if we receive biopsies and cutaneous samples from immunosuppressed patients, then once again, we want to go to the end with after histopathology, direct examination, culture, and PCR. If we are in the context of an immunocompetent patient, of course, we can have blood culture for yeast detection, but regarding respiratory samples, it will be mainly sputum. And in this case, we will perform direct examination and culture. And if we receive biopsies and cutaneous samples, then we will perform histopathology, direct examination, culture, and PCR. So I propose you to see in details what will be our process of these samples. Regarding blood, and particularly blood bottles, in case of immunosuppression, this is, for example, in the context of hematological malignancy, neutropenia, hematopoietic stem cell transplantation or solid organ transplantation, long-term corticosteroids, but we can also add biotherapies, etc. In this case, of course, blood culture will be one of the major tools to detect fungemia, and usually filamentous fungi don't grow in these bottles, except Fusarium, and sometimes Lomentospora and Scedosporium. And as nicely shown by Ronen, regarding Fusarium, we have to take care because sometimes when the bottle is positive at D0 or at D1, we can see hyaline septate and branch hyphae and sometimes phthalates, but we can also have only yeast-like forms. And it is surprising that to see after 4 or 3 days or 5 days of culture, a mold, and particularly here, a Fusarium, with hyaline septate hyphae with swollen monophyalides and reniform hyaline septated microconidia that allow the diagnosis of fusariosis. So we have to take care of this special blood culture in the case of immunosuppression, once again, as shown by Ronen. Regarding other blood samples, such as serum and plasma, of course, the first aim is to detect antigenemia for aspergillus, and probably we will implement the detection of galactomannan, and if we can also beta-D-glucan, BDG. So what happens in case of the rare mold infection? Galactomannan can be positive for Fusarium as well as BDG. And Lomentospora and Scedosporium harbor some glucans in their cell wall. So BDG can also be positive. However, in mucorales, these tests are always negative. On blood, we can also implement PCR with different targets. I remind you for Aspergillus with the 28S ribosomal RNA or mitochondrial gene. But if we look at the rare modes, now it is possible to implement Mucorals PCR targeting 18S and Fusarium targeting 28S. Regarding Lomontospora and Schistosporium, it is more complicated because we have first to perform a pan-fungal PCR targeting ITS and then to sequence. So it's not an easy tool for early diagnosis. And if we focus on these two tools, antigenemia and PCR, first regarding antigenemia, here you can see that in the literature regarding Fusarium, we have some data on the positivity of galactomannan detection in disseminated fusariosis. But we have also now some papers with the performance of BDG in the diagnosis and monitoring of invasive fusariosis. It is not the best test, but we have to know that it is positive. Regarding Lomontospora and Schistosporium, here you have a recent publication on reporting a positivity in a patient that was pulmonary transplanted. These data were obtained with the classical kits, the Biorad Platelia galactomannan and the Fungitel BDG, but perhaps in the next few years, using the new single test and easy test to use, such as LFD and LFA for galactomannan, or the new Cape Cod Fungitel stat or the WACO test, perhaps we will use more and more these biomarkers. But at this time, PCR is the most useful technique for rare modes and particularly for Mucorals. Here is one of the pivotal work that was published by Laurence Millon in Besançon in France, who reports the interest of quantitative PCR to target rhizomucor, mucor and rhizopus without distinction, and Lichtemia. And what is really interesting in this paper is that you can see here in the right that the time between the first positive PCR and the positive histology run from -3 days to -68 days. So it is really useful for early diagnosis of mucormycosis. And these results were confirmed using a retrospective cohort of 44 cases. And in this second paper, it was shown that the cumulative survival was significantly different between patients with a positive PCR compared to a negative PCR. Here you can see that the cumulative survival was less than 20% in case of positivity, compared to around 50% in case of negative PCR. So PCR is useful for the diagnosis, but also to evaluate the prognosis. And finally, the end of the story is here in this paper with a wide national prospective trial in which the performance of Mucorals PCR was reported with a sensitivity of 85% and a specificity of 89%. However, we have to be cautious because there is no ideal tool. And here you can see that they obtain a positive qPCR in 21 patients that were not infected with Mucorals. And in case of mucormycosis, 4 negative qPCR was observed. So because it is now more and more useful for the monitoring of immunosuppressed patients, we have also marketed techniques that can be used in all hospitals. And in my lab, we have evaluated the Mucorgenius Mucoral PCR that is marketed by Diagnostics. In this kit, there is one mix for the detection of rhizopus, mucor, Lichtemia, rhizomucor, and Hoenigl. But we cannot have the distinction on the mucormycete that is responsible for the infection. But if we look at the performance of this kit compared to the in-house PCR assays, the concordance was good, was very good, with 98%, and with a kappa coefficient of 0.89. So here you can see the result. And what was also interesting during this study is that using both Aspergillus PCR and mucormycosis PCR, then we could detect 40% of co-infections with mucormycosis and Aspergillus infection in very severe patients. Let's see now for Fusarium, and there is a very recent paper from Alexandre Alagnot team in Paris, who worked on the interest of a targeted PCR on blood for Fusarium, and here you can see all the species complex that were detected, as well as all the species. And what was interesting here, here you can see that the burden of the Fusarium DNA was associated to death. So once again, it is not only a diagnostic tool, but also a prognosis tool. Let's move now to the respiratory samples. So where we want to diagnose a fungal infection in immunosuppressed patients, BAL fluid is the preferred sample, and we will, of course, perform direct examination and culture. We will see it similar to sputum, so we will see that a little bit later. But what is important regarding respiratory samples and BAL is that we can perform galactomannan for Aspergillus. In case of rare mold infection, it is not so interesting because it is positive only in the rare cases of pulmonary fusariosis. And I remind you that the detection of BDG in BAL is not validated. Once again, the best tool regarding respiratory samples is PCR for Aspergillus, and we can also add pneumocystis, of course. It will be an excellent tool for mucorals. For Lomontospora and Scedosporium, it will be interesting, but at less extent, as we will see. And for Fusarium, as I said, there are only few pulmonary fusariosis. So if we look at the literature regarding PCR for these rare molds in BAL, here you can see that we can use for mucorals targeted PCR to target rhizomucor, mucor, rhizopus, and Lichtemia. But also there is an interesting paper from Laurence Millon group, once again, who published a targeted PCR for Hoenigl berthollici, and sometimes in patients with the suspicion of an invasive fungal infection, and when Aspergillus PCR and mucormycosis PCR are negative, then it is interesting to implement this Hoenigl targeted PCR. And regarding Scedosporium and Lomontospora, here you have a very nice review from Sharon Shen and Martin and Oliver and all experts on this fungi. And the fact is that, once again, there is a limit to the technique. It's that we have to perform a fungal PCR and then a sequencing. So it is less useful in routine. In case of immunocompetent patients with a suspicion of fungal infection, this is the case for chronic respiratory disease and particularly cystic fibrosis. So in that case, sputum will be the preferred sample, and we will perform first direct examination with normal or fluorescent lights and sometimes with staining. And it is possible to distinguish hyalin septated hyphae with 45 degrees angle branching that will be consistent with Aspergillus, compared to hyaline ribbon-like hyphae with 90 degrees angle branching, consistent to mucorales. If we look at the culture, there is no particular difficulty, and we can use saburo-dextrose agar, but also potato-dextrose agar. And particularly in the case of cystic fibrosis, when patients are colonized with many molds such as Penicillium and also Aspergillus, some teams are using semi-selective or selective media to detect Scedosporium and Lomontospora. Finally, if we look at the biopsies and cutaneous samples, as I said at the beginning, then we can be in both situations of immunosuppressed patient or immunocompetent patient. And particularly in this case, we can have local infections such as keratitis, post-trauma inoculation, also mycetoma with Scedosporium, and also burn patients that will be colonized and perhaps infected with rare molds such as mucorales. So here we will have 4 steps for the diagnosis: histopathology, direct examination, culture, and PCR. And usually histopathology is considered as the gold standard. But I like this, this paper because the question is, what does mean hyphae or pseudo-hyphae? And here you can see four slides with filaments. And what is interesting is to see that it is not so easy sometimes to have the good diagnosis. Of course, in a lab that is skilled in fungal infection, then it is quite easy, but in many labs, it's not so easy. And here, if you look at the first slide, it is Candida. And the morphology is consistent with Candida. However, Aspergillus, but also other hyaline fungi can be confused histologically. In the second slide, you can see hyaline septated hyphae. But what does that mean? That means that it is consistent with Aspergillus, but also possibly Fusarium, Scedosporium, Trichoderma, Bacillomyces, and mucorales. If you don't know exactly the fine tune between the filaments, the hyphae from Aspergillus and the mucorales. You can see the hyphae of mucorales in the third slide, but sometimes it can be taken for Aspergillus. And finally, you can see on the last slide that also pigmented hyphae can sometimes be confused. Here you have another typical hyphae of mucorales, but once again, this is for labs that are skilled in fungal infection. So histopathology is perhaps not the gold standard. Is it possible to refine the diagnosis? Perhaps using fluorescence in situ hybridization. And here in this paper, the authors try to use a specific staining for mucorales, and they obtained a positive signal in 58% of the samples, but they mentioned that autofluorescence was observed in 42% of the samples. So it is not completely convincing, and the authors said that there is a need for further studies. That's why, regarding biopsies and cutaneous samples, once again, molecular identification is very useful. And here, I show you how a targeted PCR regarding mucormycosis, but also ITS sequencing, allow the identification of the fungi. Here, 25 positive culture were obtained with the identification of various mucorales, but 7 were identified in addition using molecular identification. So regarding biopsies, targeted PCR or ITS sequencing is a very useful tool for mucorales identification. Regarding Scedosporium and Lomontosporiosis, then it is the beta-tubulin gene or ITS sequencing that allows the identification. And here is an example of the use of these tools to show the ventilation of the different species that were responsible of infection in immunosuppressed patients. And if we look at Fusarium, but Ronen have some slides on that, then it is also possible to identify specifically at the species level the Fusarium with the sequencing of the translation elongation factor 1 alpha and the sequencing of the RNA polymerase 2. But it is now possible to use MALDI-TOF also, mass spectrometry, and some papers report the interest of this technique to identify the fungi, and particularly regarding rare molds. We can see here that MALDI-TOF give good results compared to molecular identification, but we have to take care because for some species, here you can see Mucormycosis, we have some bad results. So it is not an absolute result, and we can use, in order to increase the agreement between molecular tools and mass spectrometry, we can use also in-house reference databases, such as the MS2 databases, published by the team of Renaud-Piarou. And here you can see that compared to the Bruker database, regarding Fusarium, regarding Scedosporium, the agreement with the molecular identification is much higher. Some other papers on the use of MALDI-TOF mass spectrometry identification, here on Fusarium with 92% of agreement at the species level. Here, within a mix of Aspergillus, Fusarium, and Mucorales fungi, 96% of agreement at the species level. And here, regarding Scedosporium, 100% agreement at the species level. So surely, mass spectrometry is a very good tool for the routine identification of the rare molds. And the last test is in vitro sensitivity testing. So what can we do with these rare molds? The problem is that using different techniques, such as the one promoted by UCAST or by CLSI, but also marketed techniques such as e-test, there is no really standard operating procedures. There is no breakpoints. And the problem is that sometimes we are limited by the low growth of time. So if we look what was said in the global guideline regarding Mucorales, the use of standard methods for antifungal susceptibility testing is only marginally supported to guide the treatment and may be clinically useful in cases of treatment failure. However, it is strongly recommended to establish epidemiological knowledge in the field. And looking at the commercial methods such as e-test, they are recommended for use, but with a marginal strength only. And the rare mold for which we have the more a huge body of data is Fusarium, as shown by Ronen. And here you can see that it is in this very nice paper, some range could be given for the most prevalent species, such as Fusarium verticilloides, Fusarium oxysporum, and Fusarium solani. Is there a place for molecular marker of the resistance? I found only one paper that was published in 2021. And here you can see that the authors sequenced the CYP51 gene of Rhizopus oryzae, and they showed that there is a polymorphism that is responsible for the voriconasal resistance phenotype. So this is a good information, but you can see here that the chimeric mutants that were obtained were posaconazole hypersusceptible. So we have to refine the data on the correlation between the phenotype and the genotype. Now we have listed many tools for the diagnosis, and thanks to Jon Salmonton Garcia, who is the first author of this paper that will be soon published in the Lancet Microbe regarding the current state of laboratory mycology and access to diagnosis. I have selected some examples in order to show that we are still working on, because not all labs have available all these tools. Regarding microscopy, of course, many of them perform a microscopy, 96%, but you can see here that in case of suspicion of invasive fungal infection, we have near than 25% of the labs that never, rarely, or only sometimes performing the direct microscopy. And if we look at the direct microscopy for suspected mucormycosis, it is less, with only 54%. Regarding antifungal susceptibility tests, we can see that only 64% of the labs perform the antifungal susceptibility for molds. So we have some way to go further. And regarding antigenemia detection and PCR, here you can see that, of course, galactomannan is widely used with 87% of the lab, but regarding BDG, it's only 60% of the lab, with 1/3 on site and 1/3 outsourced. And regarding molecular tests, of course, we want to detect Aspergillus, so you can see that 2/3 of the labs are performing Aspergillus PCR, but regarding Mucorales PCR, it is less than 50%. So in this context, what can we expect with innovation and future developments? Of course, you know that genomics with the whole genome sequencing, but also microbiota can be used as epidemiological tools, but also perhaps as diagnostic tools in order to evidence the fungal diversity, because when we have the culture, we only have a partial vision of what is the flora. And of course, you know that many papers now are published, and so next generation sequencing will probably be a new tool for the diagnosis and even for the detection of resistance, for example, using shotgun approaches. And to finish, I want to have a quick focus on the emergence of COVID-19 associated mucormycosis with this review in 18 countries that showed that regarding the clinical involvement of CNS or not, then there is an impact on the probability of survival. And with huge differences between the countries. As an example, in Western countries, for example, we implement a national study in France, and mucormycosis was a rare event with only 1.2% in severe COVID-19 patients compared to 14% of aspergillosis, sorry. But when we look at what happened in India, of course, you know that it was a major concern. So Because of this major concern in low and middle income countries, ECMM Isham published some recommendation for the diagnosis that relies mainly on the direct examination, but also on culture in order to know what is the fungi responsible. And using culture, then we know that in India, Rhizopus aresus is the most frequent mucormycosis responsible, and also to give some advice regarding the environmental factors and the host factors, and particularly in India, we have to take care that patients present mostly with diabetes mellitus, and some agricultural activities are an additional risk factors for mucormycosis. And with that, I want to thank you very much for the invitation, and I will be happy to answer to your question.
Thank you so much, Jean-Pierre. Fantastic talk, for you, really an up-to-date talk, really up-to-date literature until nearly yesterday that you included in your talk. So thanks so much for giving us, this fantastic current status of where we stand in terms of fungal diagnostics of these rare molds, including mucormycosis. So I think in the interest of time, we can have a short discussion nevertheless, with the goal to kind of like have Frédéric start in about 4 minutes. So one general question, and this may be hard to answer, is, about the specificity of beta-D-glucan, galactomannan, and PCR, whether, PCR is basically less or more specific. I mean, I guess it depends always on the cutoff, right, with PCR, or what do you have a better idea, better response than I have?
Yeah, of course, specificity is an issue because people can be colonized and people can be infected. So DNA detection and antigen detection is a marker of the presence of the fungi, and not an absolute marker of the infection. And that's why histopathology, even if I say that perhaps it's not the gold standard, but one major information with histopathology is that we can see the angio invasion of the fungi. So antigenemia and DNA in blood are interesting because they are also the biomarker of angio invasion. But when it is in the BAL or in other respiratory samples, indeed, there is a lack of specificity. But then that's why we have to combine different tests to go to the final diagnosis.
Fantastic. And maybe one final question, if I may, Esther. I would be interested, I don't know about you, but I would be interested in Jean-Pierre's response to the MALDI-TOF database question. Do you agree?
I would just like to add regarding the MALDI-TOF. MALDI-TOF is really a very good tool, but it is also very important to know which library to use. And during this discussion, there was a question why Bruker in-house is less than Bruker, because Bruker has a very massive library. And so the database that they can use is richer and enables a better identification. So I would say house-made databases are really not recommended.
So perhaps it is a little bit more complicated because we have to distinguish yeast and filamentous fungi. Regarding yeast, the Bruker database is very good. There is no problem. But regarding filamentous fungi, then we need, if we want to get a good result, first we need to extract on a different way the fungi. It is longer than for yeast. And surprisingly, when I say in-house, it is the MSC2 database that is a very, very huge, very large database with many fungi from clinical samples, from also national reference centers from different countries, etc. And the fact is that when we see the evaluation, it is better than the Bruker database for filamentous fungi. So I don't say in-house the library for each hospital, but this one, MSC2, that is an open source database. Everybody can use it free. Then the results are very good. Yeah, and now, for example, in my lab, but in many labs in France, we are using this database for filamentous fungi.
We are using here the same database.
Okay.
For the environmental fungi.
Yeah.
Thank you so much. Fantastic. So I think it's very important, especially for Maldidov and when it comes to filamentous fungi, to know which databases to use. Yeah, with that, I want to thank you, Jean-Pierre, and also invite you to respond to some of the final questions in the chat. And with that, it's my pleasure to introduce now our last speaker, Dr. Frédéric Lamoth, who is from the University of Lausanne. He has been a postdoc a number of years ago already at Duke University for a number of years. So he has spent some time there in North Carolina. And before returning back to Lausanne, where he is now an associate physician after his habilitation there, and really an expert in fungal diseases with more than 100 publications. And he's talking today about epidemiology and treatment of rare mold infections particularly, and also give an outlook about future treatment options that we may have available soon.
Thank you very much for the introduction. So the topic of my presentation is invasive rare mold infections. We'll talk about epidemiology and therapy with a focus on the novel therapies on the horizon. Here are my disclosures. So in this presentation, first, I would like to address the definition of rare mold, which are really rare molds. And then the major focus will be on the epidemiology on these rare molds with the main question, is this an emerging issue? That is, are we seeing that there is really an increase in the total number or in the proportions of these rare molds? And then we'll talk about the new therapies in the pipelines for these molds which are notoriously resistant to many antifungal therapy. So what are we talking about rare molds? Usually we talk about non-aspergious molds. The question, should we include Mucormycosis in this or not? And finally, why not some aspergious species? Because there are also rare aspergious species, like some cryptic species, which may actually behave the same as some rare molds. So rare, actually, it depends really on the epidemiological context. For instance, mucormycosis is much more frequent in India compared to Europe. And if you look also to disseminated fusariosis, it's relatively rare in Europe, but very frequent in Brazil, as frequent as aspergillosis in hematologic centers in this country. Actually, what we should look at when we refer to these rare molds, they share some common features which is important to outline. First, they have this propensity to disseminate, to make disseminated disease with extrapulmonary sites of infections, which could be primary sites or secondary sites outside of the lungs. Well, it's well known for mucormycosis with rhinocerobutyl, cerebral abdominal mucormycosis. But then you can have fungemia, which is rare for most. You can have fungemia, as we have seen for fusariosis, about 40%, Lomentospora prolificans, also about in 50% of cases, and for instance, Puprocellular in some cases. Then they often make skin disease, skin lesions, which can be primary lesions, but also secondary lesions after disseminations. This is frequent for fusariosis, but also seen in scedosporiosis or in scopuliopsis infections. They have also a propensity for some of them to affect the brain, like scedosporium, the heart, like scopuloiopsis. So this propensity to disseminate outside of the lung, I think, is important. Then, of course, you have limited therapeutic options. These molds are resistant to many antifungal drug classes, and usually you rely on a single or sometimes two drugs for their therapy. And of course, you have also some notoriously multiple resistant molds, which are almost resistant to all antifungals, like Fusarium solani, like Clematospora prolificans or Scopuloiopsis species. So as a consequence, they have a high mortality rate, and importantly, high mortality despite antifungal therapy, which means that actually the outcome does not essentially rely on antifungal therapy, but also on other interventions like surgery, mainly for mucormycosis. In the absence of surgery, the prognosis is very poor. Recovery of immunosuppressions, very important for fusariosis. Without recovery of neutropenia, almost 100% of death. So these are important characteristics. And I would say that instead of rare molds, we should prefer the terms refractory mold infections when we are talking about these kind of infections. Now focus on the epidemiology of invasive mold infections, especially for these rare molds. Here I show the results of two big surveillance programs, one in North America, the Transnet network among transplant patients, hematopoietic stem cell transplant patients, or solid organ transplant patients, and the Siphon in Italy for hematologic cancer patients. And as you can see, of course, a large predominance of Aspergillus species, about 2/3 in the United States, even higher in Europe, more than 90%. And then Mucorales would account for about 5 to 10% roughly. And then come other molds. Among other molds, these are very variable proportions according to the country, but you will have Fusarium, Scedosporium, Lematospora, Bacillomyces, etc. Now, these studies that I showed are mainly data before 2010. But actually, we have seen since 2010 dramatic changes in the epidemiology of fungal infections. Some major public health issues like the emergence of Candida auris since 2009, the shift from the Candida albicans to the non-albicans Candida, which are more resistant. We have seen the emergence of other resistance in Aspergillus fumigatus, which has spread on all the continents. And of course, also recently, we have seen the problem of invasive aspergillosis in ICU, mainly with the influenza pandemic H1N1, and then with the dramatic COVID-19 pandemics with invasive aspergillosis and also mucormycosis in these ICU patients. Then we have also some warnings, some emerging issues that we should closely monitor. For instance, the rise of echinocandin resistance among Candida, especially Candida glabrata. The expanding geographical distribution of Cryptococcus gattai, but also some endemic mycosis. The advent of invasive aspergillosis associated with novel anti-cancer therapies, mainly tyrosine kinase inhibitors like ibrutinib. Some centers also report an increase in incidence of mucormycosis. And we can also ask the questions, are we seeing actually also an emergence of these rare mold invasive infections? Which could be the trigger of these epidemiological changes? First, the human activities. Of course, the use of antifungal drugs, mainly in hospitals, antifungal prophylaxis or treatments, but also the fungicides in agricultures. And then the changes in the host, novel therapies, as we have seen, possibly also contaminated medical devices or medical rooms, like it was the case for Candida auris, and possibly immigration on wars. And then you have the environmental changes. We can ask the question whether global warming could affect the epidemiology of invasive mold infections. The natural disasters, which are possibly associated with global warming, hurricanes, tornadoes, tsunamis, and of course the recent pandemics that we have, mainly the COVID-19. So these have an active impact, a direct impact on the epidemiology of invasive fungal infections. But on the other side, we also have what I would call the passive impact, which will actually not really affect the epidemiology of invasive fungal infections, but change our perception of this epidemiology because, for instance, we have a better insights in this fungal epidemiology, mainly with new or improved diagnostic tools like PCR. Many fungal infections that were before classified as possible could be more accurately identified. So this may change our perception of the epidemiology. And also the improvement in surveillance programs for the detections of emerging fungal pathogens like Candida auris, also the emergence of resistance. Now, if you focus on mold infections, what could affect the epidemiology of these rare mold infections? First question is posaconazole prophylaxis. As you know, we had two big randomized controlled trials which clearly demonstrated that posaconazole prophylaxis compared to a non-mold active prophylaxis like fluconazole or itraconazole was able to significantly decrease the incidence of invasive mold infections, especially invasive aspergillosis. This was shown in two categories of patients, patients with hematologic cancer and pulmonary neutropenia, and allogeneic hematopoietic stem cell transplant patients with moderate or severe graft versus host disease. And the guidelines have now implemented posaconazole prophylaxis as a strong recommendations with high quality evidence. So once we start giving posaconazole prophylaxis to the patients, we reduce the incidence of invasive aspergillosis or invasive mold infections in general, but we will see breakthrough invasive mold infections, which means invasive mold infections occurring under posaconazole prophylaxis. On this slide, I have reviewed actually all the papers since the publications from Connolly and Ullman, who report the incidence of these breakthrough invasive mold infections in hematologic cancer patients under posaconazole prophylaxis. And I have identified 35 papers between 2009 and 2022. And as you can see, the incidence of these breakthrough infections is extremely variable. Here you have the incidence of the Connolly paper as a reference at 1%, Ullman in the transplant hematologic patients at 4%, and you see that some of these papers report an incidence close to 0%, some other between 5 and 10% or even higher, so extremely variable. Now, if you look at the type of invasive fungal infections, which are these breakthrough infections, we see that still a majority are invasive aspergillosis, up to 80%, in many cases based only on a positive galactomannan, and then 50% invasive mucormycosis and other mold infections in less than 10%. So it means apparently not a big change in the proportions, and it does not seem based on this that these rare molds are really an emerging issue. But now I'd like to give you some insights on my personal experience with this, and I would like to show you first a case. This was a patient with allogeneic hematopoietic stem cell transplantations for acute myeloid leukemia, and she had a very complicated history. Finally, she was in complete remission, but she developed a severe graft versus host disease with intensification of the immunosuppressive regimen, and she was put on antifungal prophylaxis with posaconazole with acceptable trough concentrations. Nonetheless, we observed that she has an increase of serum galactomannan while she was completely asymptomatic, no fever, and she was well and followed at the outpatients clinic. There was a complete CT scan, head, chest, abdominal, everything normal. So a dermatologist said, okay, it's probably a wrong, false positive galactomannan. But 3 months later, this person came back to the consultation and she was still fine, no fever, but she complained of 4 subcutaneous nodules that were painful in the back and on the shoulder. Galactomannan at this time was 6.4, and the biopsy showed hyphal elements, biopsy of these nodules. At the culture, we found an Aspergillus species, but a non-fumigatus Aspergillus, which was sent to our reference laboratory for further identifications. And this is how it looks like. This was grayish on the top, yellowish on the reverse, on the biseriate aspergillosis. So what do you think it is? If the the experts panel, the chair or other speakers would like to try to answer, you're welcome. Do you think it's an Aspergillus sudagawe, which is a cryptic species of section fumigati, an Aspergillus calidoeustus, Aspergillus nidulans, or Aspergillus versicolor? Okay, so the response is calidoeustus. This is an example actually that some Aspergillus can be rare molds and behave like rare molds. If we reviewed all the cases of this Aspergillus justi, section justi, invasive aspergillosis, we identify 72 cases, 45 from a literature review, and 27 were prospectively collected from 22 European centers via a questionnaire. And we see that these patients are mainly non-neutropenic transplant patients, bone marrow transplants or solid organ transplant patients, and that half of these cases are breakthrough infections, while mold active prophylaxis is ongoing, mainly voriconazole or posaconazole. And you see that this type of aspergillosis share the characteristics of these rare molds that we have seen before: high propensity for disseminations, 32%, and also in 1/3 of cases, skin lesion, soft tissue lesions like we have in our case, and up to 40% also brain involvement. The majority of cases are due to calidoeustus, which is actually one of the unique species which is thermotolerant. And not surprisingly, this Aspergillus species have intrinsic resistance to azoles, mainly voriconazole and posaconazole, the reason why they do breakthrough infections. And mortality rates is particularly high among these patients. So again, a type of Aspergillus which has the same characteristics of these rare molds as we have outlined before. Now, is this an emerging issue? During my stay at Duke University, I compared actually the fungal pathogens in the breakthrough invasive mold infections versus the non-breakthrough infections. And I found 29 fungal pathogens in patients receiving voriconazole or posaconazole prophylaxis. And you see, compared to the 85 fungal pathogens in non-breakthrough. In non-breakthrough, you have a predominance of Aspergillus species, not surprisingly, in gray, and half of them were Aspergillus fumigatus. But then in the breakthrough, you see a significant shift from the Aspergillus to the non-Aspergillus ones, and mainly to these rare molds, which are molds other than Mucor, Fusarium, Scedosporium. And these were molds that are, for most of them, notoriously resistant, intrinsically resistant to azoles, like the Scopulariopsis, the Lomentospora prolificans, or Rhizomsonia. And you see also, among the Aspergillus, there was a significant shift from the fumigatus to this famous Aspergillus justus, also intrinsically resistant to azoles. So it seems, based on this study, that actually posaconazole prophylaxis may result in some shift of the fungal epidemiology towards these rare molds. Now, regarding breakthrough invasive fungal infections, I have a second clinical situation that I would like to show you. Again, a patient with acute myeloid leukemia receiving the second induction chemotherapy and receiving posaconazole prophylaxis. And he had first episode of febrile neutropenia, and then a second recurrent episode. And because of persistent fever, we did a chest CT scan. And as you can see, we can see the typical well-circumscribed nodular lesions with some ground glass opacity around, so very evocative of an aspergillosis. And interestingly, the posaconazole trough concentrations were not optimal. They were between 0.3 and 0.6, so not that good. We did all the diagnostic workup, negative galactomannan and beta-glucan serum, bronchoscopy, everything negative in BL, and we start the patients with ambisome. So what to do at this stage with a possible invasive fungal infection? We did a biopsy, a lung biopsy. And on the tissue, we could see mycelial elements. And this is the results of the panfungal PCR. We did the panfungal PCR targeting the 18S ribosomal DNA from the paraffin slide. And you see here the first hit is Marasmus alliaceus. And then with scores that are relatively close, you can see other moles, Laccaria, Cristinia, Pelotopsis, so not really what we are used to see as our common fungal pathogens. And actually, if you go on Google and you have a look on which kind of molds these are, you see these are mushrooms. These are Basidiomycetus molds, which are, for most of them, edible mushrooms. So what do you think about this? Do you think it's really Mariasmus aliaceus, the pathogenic agent? Do you think it could be another Basidiomycetus mold like Schizophyllum commune or Homographiella aspergiata? Or do you think, well, on a paraffin slide, not strial material, this is definitely a contamination? So I give you the response, and the response is this. Actually, we did a second panfungal PCR targeting now the 26 ribosomal DNA, which is supposed to be less sensitive but more specific. And this gave clearly the identification as Coprinopsis cinerea, formerly Coprinus cinereus. So what is this mold? Again, this is a mushroom. This is called as the gray shag. It is edible, not very good, it seems, but it's edible. So again, surprisingly, but we have to know that this fungus has an anamorph form. This is the teleomorph form, Coprinopsis cinerea, but there is the anamorph form, which is Homographiella aspergiata. And Homographiella aspergiata is a rare but well-known fungal pathogen. There are about 20 case reports in the literature, mainly in patients with hematologic cancer. Again, breakthrough infections in 25% of cases, mainly patients under mold-active azoles, mainly primary pulmonary infections, like in the present case, but with a propensity to affect the brain, 20% of dissemination to the brain, and again, very high mortality. Interestingly, you can see that MIC to voriconazole is quite low, and actually voriconazole is the recommended therapy. But posaconazole MIC are somewhat higher, and there is some trailing effect, which means there is some residual growth above the MIC. And remember, in this case, the trough concentrations of posaconazole were suboptimal. They were not within the targeted range above 0.7, they were below, which could explain why this patient did a breakthrough while under posaconazole prophylaxis. So we have seen the possible impact of this posaconazole prophylaxis on breakthrough infections and the change in the epidemiology of mold infections. Now we can ask, are there other factors that may affect mold infections? And I have listed here some type of events that we have observed recently and which gave rise to some clusters or burden of rare mold infections. So of course, the most important one, as discussed before, is the mucormycosis burden during the COVID-19 pandemic, mainly in India. But remember, we also had this important outbreak of Exeroil umbrostratum meningitis in US, which was associated with the contaminations of corticosteroid injections. So again, a rare mold, which is very rarely pathogenic here. Novel anti-cancer therapy like ibrutinib can cause aspergillosis, but also some case reports of mucormycosis. And natural disasters have been associated also with invasive fungal infections like cutaneous mucormycosis after the tornado in Joplin, scedosporium infections following some tsunamis, or some rare outbreaks of Bacillomyces after an earthquake in Chile. So we can also ask, is there an impact of global warming on molds, on these rare molds, possibly on a shift, on an extension of their geographical distribution? And I show you here this last case of the presentations. This was again a patient with acute myeloid leukemia during his first injection chemotherapy, not receiving posaconazole prophylaxis, but fluconazole prophylaxis. And these patients had a recurrent neutropenic fever and a positive beta-glucan, which motivated a switch from fluconazole to caspofungin, mainly for a suspicion of invasive candidiasis. But on the CT scan, again, we saw two nodular lesions with some halo signs, so very suggestive of aspergillosis. Again, everything negative, BAL, everything negative. So we went to the biopsy, via endobronchial ultrasound guided biopsy during the bronchoscopy. And the culture was negative, the PCR was negative, but the histopathology showed mycelial elements which were called mucor-like. And I show you the picture. Actually, the pathology says like mucor because they are broad hyphae. But when I saw the picture, I was surprised because yes, these are very broad hyphae, but septate. If you can see, there are lots of septations. And this is quite surprising for a mucor. So again, we did the fungal PCR on this. So what do you think we found? Some rare mucor species. So it was a Conidiobolus. Actually, Conidiobolus, just to remind you, are somewhat distinct from Mucorales, but they were formerly in the same subkingdom of Zygomicota. So they are kind of cousins of the Mucormycosis. They cause entomophthalomycosis because they are parasites of insects. They are present everywhere in the environment, but it is supposed to be a tropical disease or subtropical disease because the optimal germinations and proliferations occurs at high humidity level and relatively high temperatures. It can cause, for instance, conidiobolomycosis, which is a subcutaneous infections of the face, also called rhinofacial elephantiasis, which can be seen in Africa, Central South America, or in Asia. There are also cases of invasive infections due to Conidiobolus reported in immunocompromised patients. This is rare, about 10 case reports. And interestingly, you can see that here, before 2010, most of these cases were reported in tropical or subtropical area, like in southern USA, in Asia, India, or Thailand. But from 2010, we start to have some reports of these infections, also in northern US, in Europe, in Switzerland, like in this case, or in Japan. And it's interesting to note that when we have this case in Switzerland, it was summertime, and we had a big heat wave at this year. This was the hottest winter, the hottest summer we had in Switzerland for many decades. So possibly an example that global warming could affect the geographical distributions of some of these rare molds. So we close these presentations with the therapeutic challenges. So as you know, therapies are very limited for these rare molds, and in many cases, they are at least intrinsically resistant to many antifungal agents, and there are very few agents that are active in vitro. Usually just one drug, one single drug, or sometimes one active and one possibly as an alternative but less active. Among the novel therapeutic options, there are mainly two drugs with very promising results in preclinical studies. Phosphomanogepix is a product converted to manogepix by phosphatase. It's an inhibitor of the glucose phosphatidyl inositol biosynthesis, so it will affect the cell wall integrity. Importantly, it can be given by intravenous, but also by oral routes, by pills, and it has a good brain penetration, which is important for these rare molds, which have sometimes a propensity to affect the brain, like Scedosporium. Olorofim is an inhibitor of pyrimidine biosynthesis. It alters DNA replications and cell wall integrity. Again, we have both intravenous and oral formulations, and again, a good penetration in the brain. If you see the spectrum of activity, most interestingly, this drug has very good in vitro activity and also in animal models against Scedosporium or Lomentospora, and also against Fusarium, mainly for Phosphomanogepix. Also against some rare molds, notoriously resistant molds like Scopulariopsis, but the major gap is Mucorales, for which they are not active like Olorofim, or only have marginal activity like Phosphomanogepix against some Rhizopus. But at least a very big promise for this pan-resistant mold like Lomentospora, Fusarium solani, or Scopulariopsis. We have currently phase 2 trials that are ongoing for rare mold invasive infections, for Phosphomanogepix, and another one for Olorofim. So in conclusion of this presentation, epidemiology of non-aspergillus small invasive infection is possibly changing with a trend towards increased incidence and higher proportions, possibly impact of the implementation of posaconazole prophylaxis. but possibly other factors like global warming, climatic changes, and also the impact of improved diagnostic tests. Because I remind you that in the two cases that I presented, the Homographiella and the Hoenigl case, these were diagnosed only by PCR. So possibly these cases 10 or 20 years ago would have been missed. And finally, novel therapeutic options are expected to improve the prognosis of these infections, mainly for fusariosis or scadosporiasis, stromatosporiosis, and fusariosis. Thank you for your attention.
Thank you so much, Frédéric, for really an outstanding talk and fantastic cases. So we all wonder, you know, when we travel next time to Lausanne, whether there is just a certain spectrum of fungi we need to be aware of, or more likely people in Lausanne are just so good on diagnosing these infections.
We still have more than 90% of aspergillosis.
And also, I think very important point for highlighting the cryptic Aspergillus species, Aspergillus ustus group, and, you know, also the rare Aspergilli, which very much, you know, are clinically as relevant as other rare mold infections in terms of antifungal susceptibility. We have a number of interesting questions. The first goes in line with my comment, basically asking about the epidemiology of fungal infections in Switzerland specifically, and how it compares to the rest of let's stay within Europe, the rest of Europe, over the last 20 years. Any insight on that, Frédéric?
Yes, I just showed here the rarity, but we have more than 90% of aspergillosis. But in my institution, within the last 3-4 years, we see really an increase in mucormycosis, definitely. And this could be linked to different things. We have implemented the mucor PCR about 2-3 years ago. So possibly we've improved our diagnostic approach. So this is an example that actually improved diagnostic tools may provide some apparent change in the epidemiology, but also we have a huge works, building works renovations close to the hospital. And I think it's actually the main reason for the increase of mucormycosis. And in Switzerland, we see a majority of rhizomucor in my institution, not Leishtemia, but mainly rhizomucor. And then we have almost no fusariosis. I have seen, I think, in 10 years, a single case here in Lausanne. And well, these very rare cases that I've presented are really very exceptional.
No, exceptional indeed, and extremely interesting. But we had, for example, also an Aspergillus calidostus in Austria, and we see more fusarium. So it really highlights you need to know your local epidemiology, yes, because Lausanne is not super far away from Graz, actually, but right, the epidemiology may be very different, and even within countries, even national epidemiology from hospital to hospital.
You're perfectly right. If I compare to Geneva, 40 kilometers away, it's different.
Yeah, so I think that's a very important message. Yeah, I get lots of applause, lots of hand clapping about, you know, a fantastic talk, and also a great webinar, so also great job by others. Yes, some more question maybe about increasing resistance to antifungal drugs. How can awareness be increased? I think that's very important. I mean, you showed, Frédéric, there is finally, we have, you know, some new antifungal drug classes in the pipeline that hopefully will get to the market and will help us treat some of these multi-resistant fungal infection and find new treatment strategies. So any response here from you, Frédéric, maybe treatment strategies that go beyond novel antifungals, anything on the horizon? Obviously, it's not close, but anything to say about that? Targeting some immunological mechanisms, for example?
Yes, there are big expectations, of course, for these novel antifungal therapies, but targeting also the host immune system is promising. We have now a trial with interferon gamma plus antifungals for candidemia. So I think really, as we have seen for fusariosis, recovery of neutropenia is essential. So I think really options that will consider both the pathogen and the host side are really crucial for the future in the treatment, the management of these infections.
Fantastic. Esther, any question from you?
Yes. Well, basically it's a comment, not so much a question. Seeing these cases, this very rare cases, some of them, very rare fungi as well. This puts me basically to something else, that we should study our environment, because what is in our environment may eventually end up in the patient. So, and as you very well know, my interest is in environment. So I think this is an important point where the regions may be different, the environment may be different, and this is then expressed later sometimes in the diversity of the patients.
Yes, I think it's right. It's important, and we see now with this important renovation building works, we see an increase in mucormycosis. But actually, it's quite difficult to. We can see these associations, but it's difficult to demonstrate this. We tried to look in the environment, actually in the rooms. We did fungal culture from the different taking hair or just putting some plates in the rooms, and we tried to catch some molds, but we could not be able to demonstrate these associations. But I'm sure you're right. What we have in the environment is crucial.
But Frédéric, if I may give a comment, plates is not sufficient. You have to take bioimpactors.
Yes, that's what we did actually. We did both. We did with bioimpactors and with the plates. Mm-hmm.
Yeah, because plate is only
yes.
The result of the sedimentation of what is in the air. Mm-hmm. You cannot calculate a concentration of spores without an air sample.
We put the plate just at the opening of the ventilation system, and then in the room we used the aspirator.
Okay.
I would like also to add something. I probably didn't thank so much as I should have thanked Ronen Ben-Ami for a very, very special case that he showed. And thank you, Ronen.
Perfect. Yeah, I can't agree more that this webinar was excellent, really, from the start to the finish, from the case over Jean-Pierre's talk on diagnostics, over Frédéric's talk on therapeutics. And I think this also is the perfect timing now for us to come to a close. And thank all the speakers and thank you all. And I just have some final slides I want to show before we finish up, and potentially, depending on where we sit, but at least for us in Europe, maybe have dinner with our families. So this brings me to the conclusion of this webinar. As with the previous webinars, the good thing is, if you have joined, of course, you were able to participate in live discussions, interact with the speakers, with the expert we had here. But there will also be an on-demand version of the webinar available for all of your colleagues who may be interested but didn't have time to join today. And we will again notify you once this version is available. And you can also get credits by watching this on-demand version. And with that, basically, I want to thank again our excellent speakers, thank my co-chair, Professor Segal, and thank all of you for your participation and great discussions. And wishing you a great evening or great day, depending on where you are. Thank you.